Ready?
Yeah.
Okay. So does everybody see the screen okay? So Angie and I work together to go over this for both the preferred regimens, depending on what the insurance the patient may have for both Hep C and HIV. So I have a little overview here with the slides. So I'm primarily going to focus on, like I said, hepatitis C for both Medicaid and the Public Employee Insurance Agency, or PEIA. Another thing I want to touch base on is one of the plans here in West Virginia, the West Virginia Highmark Blue Cross Blue Shield. Picking these mostly because the majority of our patients, at least that we dispense for in the pharmacy and that we see here, have Medicaid and PEIA, and then this Highmark plan is also one that we see most commonly. So just to touch base on those. And then Angie's going to go over the HIV regimens, a little bit of background, and also Medicaid PEIA criteria, as well as the Ryan White program. Okay, so first of all, the criteria for approval, I think everybody here is really familiar because we've talked about it ad nauseum, but just to kind of note some differences. So West Virginia Medicaid's pharmacy benefits are provided by Rational Drug Therapy Program. So think of it more as like a third party. When you're doing the authorizations, you're not sending it to Medicaid, you're sending it to Rational Drug Therapy, and they're charged with making sure that the patient meets the criteria that have been set forth for approval. And then the link there for where it says criteria should take you, if you click on that in the presentation, will take you to the criteria on the Medicaid website. But it's two of the things that still stand out is that they do still have to be prescribed by or in conjunction with a specialist, and that the fibrosis score is still required to be at least F2 or greater. The last time I got an update was that West Virginia, Ohio, and Maryland still have F2 criteria, but the other surrounding states, PA, Kentucky, and Virginia have lifted those. So we're still working on that. I've heard rumblings that maybe. Right now it's still F2 is set. And then the other important thing is to make sure your patient fills out that patient consent form, where the patient reads and signs off that they're going to follow the treatment plan, including follow-up. And that's something that has to be submitted in addition to the lab work and everything for the authorization. And that's for Medicaid specifically. The other plan, PEIA, they have a similar setup, but rather than sending it to RDT, you're sending it to a different third party, Health Smart, where they administer the pharmacy benefit there. But the easy thing to remember is that they follow all of Medicaid's criteria. So you don't have to learn anything different as far as what you need to submit or the preferred regimens, because they're doing all the same things, including that patient consent form. They also require that that be filled out and submitted with the authorization. Okay, so I focused primarily on genotypes 1, 2, and 3 for these, since that's what we see most commonly here, and treatment naive. So this is West Virginia Medicaid and subsequently PEIA's criteria. I have them both listed here without cirrhosis and also the patients that have compensated cirrhosis. The main thing to point out here is that you have options within the non-cirrhotic patients. You have 4 different treatment options, but I want to highlight that Harvoni for 8 weeks is the only Harvoni regimen that you're going to get from West Virginia Medicaid or PEIA. If your patient does not meet criteria for the 8 weeks, like if they have HIV, viral load greater than 6 million, African American, you're not going to request Harvoni because they don't meet criteria for that 8 weeks, and they're not going to approve a 12-week regimen. It's not on their preferred list. So like Dr. Rexrode's patient, if you have a clinical suspicion that maybe they're a little bit more advanced in their fibrosis and you would be hesitant to treat them with 8 weeks, you would just, for a Medicaid patient, choose one of the other regimens instead. You can see in the compensated cirrhotics where, per the guidelines, Harvoni times 12 weeks would be appropriate. Medicaid's not going to pay for that. It's not one of their preferred regimens. But they do require the NS5A resistance testing if you have a 1A patient. You're going to try for Zevactir. And then the nice thing about genotypes 2 and 3 is these next 2 slides are the same. So you have 2 regimens, treatment options from Medicaid and PEIA, either Mavorite for 8 weeks or Eclusa for 12 without cirrhosis. And then the Mavorite regimen is a little bit extended if they do have compensated cirrhosis. And that's true for genotype 2 and genotype 3. Okay. So a little bit more information too, because I know this can be really confusing. So West Virginia Medicaid patients can fill at any willing pharmacy that is registered for Medicaid. It does not have to be a specialty pharmacy. If the pharmacy is willing to purchase their Hep C medication, they can get it wherever they want. Their copay is usually anywhere between $0 and $3, which is nice because any government-funded insurance we cannot use manufacturer-supplied copay cards for. So that goes for Medicaid, Medicare, TRICARE. We cannot use copay cards for them. They would have to go through another means of foundation assistance to get those copays paid for. But that's okay for our Medicaid patients because it's $0 to $3 and only for usually 2 to 3 copays. Little bit different for PEIA patients because HealthSmart has contracts with 2 specialty pharmacies, CVS Specialty and Accredo. So those patients have to use one of those 2 pharmacies. I have not figured out exactly how they have decided which pharmacy the patient has to use, but when you get the authorization letter, it will tell you which pharmacy it has to go to. So that's where you'll have to send your prescription. They are not a government-funded insurance, even though they follow Medicaid's criteria. So those patients do qualify for a copay card through the manufacturer. And I wanted to bring that up because I've had several patients where they've had to use those pharmacies and not all of them, it seems to be hit or miss whether they actually get them a copay card. So some patients don't start because their copay is astronomical. When we could fill hepatitis C medications before this contract was in place, the average copay for a patient for Epclusa was $4,500. So they need those copay cards. So if they can get those online, they're relatively easy to get. We usually try to help our patients get them, but generally all it requires is an email address. And they send them that information and they can supply that to the pharmacy to take care of that copay. But I just want to point out the PEIA, they do qualify. They can get those copay cards. So changing gears to a different plan. So this is the West Virginia Highmark Blue Cross Blue Shield plan. And the reason I'm bringing up is there's a lot of variability in this plan. So I have their criteria listed here. And the criteria seems to be standard across the board for all Blue Crosses we've ever done authorizations for, pointing out that their lab work has to be within the last 6 months. They want to know the patient's renal function, that it's greater than 30, and that they haven't had any drug or alcohol use in the last 6 months. And we've been burned on this because they don't ask for this information on the actual form. They just expect you to know that that's what it is. So we've just kind of gotten privy to the fact that we have to supply this information to them to get the approval because we were getting denials back because we didn't submit a GFR. You didn't ask for one. So, and we asked for Mavorite, it doesn't matter anyways. But they do want that stuff and it's kind of like a stopgap for trying to get these approved. So as far as the drug and alcohol use so far, they haven't required a specific actual like a blood or urine test or anything, so long as you just attest in your clinical note that you submit the patient has been drug and alcohol free for at least 6 months has worked for us so far. And the reason I'm bringing this up is that this is one of the insurances that's available through the marketplace through the Affordable Care Act. So the patients are able to purchase this, but the preferred regimens on the next slide are going to vary depending on which plan the patient selected. So these are for genotype 1 are the alleged preferred regimens for these patients. Okay, so they don't really differ that much from the guidelines, or really it just looks like there's a lot more options. So you'd look at this and think like, hey, I have my choice. I can actually prescribe whatever I want. But I know specifically Kaylee has been involved in this because we've had problems where we see this and we say, okay, we want to submit Harvoni for 8 weeks for one patient. And the representative said, well, actually the plan he chose was our very basic, cheapest plan. So the only thing that he's actually approvable for is Viekira. Wow. So even though it looks like the preferred regimens, we had a lot to choose from, that patient got stuck having to do Viekira, which was a 12-week regimen rather than the 8 weeks, which you would think would be cheaper, but
It's all rebate driven.
Yeah, it's all based on the insurance. So just keep in mind that not all Blue Crosses are created equal. And even within the West Virginia Highmark Blue Cross Blue Shield, those aren't created equal either. And then for genotypes 2 and 3, the next slide, they're the exact same as what you would see on Medicaid for this plan, depending on which plan the patient has. And two other points that I wanted to bring up too, they are discontinuing some medications. So AbbVie announced that they were going to discontinue the Viekira XR, because there are 2 formulations of Viekira. There's the Viekira Pak and the XR. They're going to discontinue XR. They're also going to discontinue Technavy, which is marketed for genotype 4 patients. So we don't see those around here very much. They were supposed to be available through January, but they were going to continue making the Viekira Pak. The other one that's being discontinued is Declenza, which is made by Bristol Myers. This one is supposed to be available through June of this year. I went to see if we could order any of these products, and at this time, our pharmacy, it looks like our wholesaler doesn't have any of these. So even though we're supposed to still be able to get Declenza until June, and Viekira Pak is still supposed to be made, the supply is so short that it doesn't look like we can order it. So if any insurance would come back and tell you that one of these is the preferred regimens, I would probably fight that, only because I would be weary that either you won't be able to get them started, or you'll start them and then the pharmacy won't be able to get them anymore, and they won't be able to finish therapy. So I just wanted to bring that up. And then we also touched base, Dr. Feinberg brought up the available generics that are going to be coming out for Harvoni and Epclusa. Both of those are available. We can order them in the pharmacy. I have not yet seen an insurance company prefer those, other than seeing that Louisiana was going to potentially do that, move forward with their Medicaid program. But none of the insurances that we've tried to do authorizations for have requested we use the generics. You can see the price difference there is significant. Compared to also for a 28-day supply, Maverick's like $13,000 for a 28-day supply. So we are getting cheaper and cheaper options for these patients, but it's going to depend on the insurance and what they prefer and the rebates they're getting on the backside, how much this would potentially save them.
I'll just add to that. It's not uncommon that they'll prefer a branded name product in these scenarios, because they'll never share that data. It's not transparent data, but the rebates are so significant that you say, well, how in God's name could someone pick the $31,000 over the 12? Well, the rebate gets that number below that 12 in some scenarios there. And, but again, that's not transparent in public data, but that's why that happens. And that's why they continue to push for those products in those scenarios there. So that's not uncommon.
So for the HIV preferred regimens, so I put a little bit of statistics on with this. You can get the next slide, because I know this is a newly emerging problem within our state. West Virginia is still a low prevalence state, but I know it's something we've definitely got our eye on right now. So as of now, or as of 2017, when this data came out from the HIV surveillance study in West Virginia, we had about 1,800 people living with HIV and AIDS in West Virginia. And they're looking at the instance of new cases coming out. And from 2012 to 2016, we had about 81 new cases per year during that period. In our top 5 counties to report greater incidence, those are going to be your larger metropolitan areas, so Kanawha, Raleigh, Cabell, Berkeley, and Mon. And then the highest prevalence, so the first statistic was the newly diagnosed cases. The highest prevalence are along the same lines, a little bit of a different order. Martinsburg has the highest prevalence, followed by Kanawha, Cabell, and then Raleigh and Mon. And those are just the biggest cities in the state. So just to give you an idea of how many people are covered by the Medicaid, that stat includes CHIPs, but it's about 500,000 lives that are covered under West Virginia Medicaid. And the population of the state's about 1.8 million. So we're looking at about 30% of the residents are covered under the Medicaid program with the expansions. We have a high Medicaid population in the state. And then there's also about 7.5% of West Virginians that don't have health insurance at all. So getting HIV coverage for them is an additional burden and something to think about too. So for Medicaid, the non-preferred medication regimens do require prior approval. So that would be a call to Rational Drug. We handle those. Medicaid does stipulate that if they are started on a regimen, then we can just approve them to continue. They won't ask us to force any changes. If the patient's on a regimen, it's detrimental, of course, you know, to switch them to something else. So if someone is stable, it does necessitate a call because we don't have a way to know that they're stable, but those will be approved for those patients to continue on those regimens. The pharmacy restrictions, like Rachel said, they're pretty lax. They can be covered anywhere that is contracted with Medicaid. So that's usually most of the pharmacies within West Virginia, and then on bordering counties, they're usually contracted with West Virginia across the state lines. So they can go to any pharmacy that can provide the medication. There is a new rule as of October 2018, which everybody's probably already aware of, that the providers have to be enrolled with Medicaid to have any medication, not just HIV medication, covered by Medicaid. And there are 3-day emergency supplies should you get into an emergency situation with a patient and they're out of medication and they need it today. You can always do emergency 3-day supplies for that. And we already covered that, so we can go to the next one. And this is a really convoluted slide. It's just on there for completeness. What I would recommend for Medicaid, it's really easy just to go on Google West Virginia Medicaid Preferred Drug List. It's going to be the first link to come up. We can go to the next one. There is a URL for the Medicaid website, but usually for callers calling in, we don't even bother to give that because it's such a long URL and it's got a % sign in it and it's just way too long to remember, so we just tell everybody to Google it. It's pretty easy to find. The PEI formulary, I included that because that is a little bit more of a bear to find. So there are the different tiers for the coverage for the plans. They can pick different plans within PEIA and they have varied amounts of deductibles and varied amount of coverages for copays. So it's really difficult to predict what copays would be. But generally speaking, the tier 1s are cheaper, the tier 2s are the next level, and the tier 3s are going to be the most expensive. So that's there for your information. And that's our long website, but as I said, just Google it. It will pop right up for you. Call to Rational Drug would be how you get the approvals for the Medicaid program, and our phone number and fax number are on the form and on that slide. For PEIA, the non-specialty meds go through Rational Drug, but this would be a specialty med category. Those you would go through a company called HealthSmart. And we did just get notice that they are switching the specialty med provider for PEIA. That's going to be a company called UMR starting July 1st. We haven't been told yet if there's going to be formulary changes. I would foresee that there likely would be, but we haven't gotten any specifics on that quite yet. And switching back to the Medicaid program and the Ryan White program, we'll cover that just a little bit because it is an important part of the coverage for patients in the state. So this is a limited pharmacy services plan that patients can enroll in if, say, they don't qualify for Medicaid coverage. So this would be something that would cover their HIV medications, and it also covers some other medications that they might need that would not be specific antiretroviral therapy, but they would need due to the fact that they are diagnosed with HIV. So that program will cover those medications. And it also offers copay assistance for patients who have other coverage if they enroll with that. And the websites to enroll with that and the forms to fill out are with that link at the bottom there. And for PEI, this is their formal statement on where their tiers lie, and it's very vague. It just says that the patients pay a 75% coinsurance for brand name for the highest cost tier. That's usually pretty consistent. The middle and lowest cost, it just depends on which type of plan that they pick. So their copays are very varied. But they do have no prior authorizations for antiretrovirals for that plan. They're structured a little bit different than Medicaid in that they're going to reel in by charging more. So their copays are not going to be, so with Medicaid, if you get an authorization for non-preferred medication, it's going to be around $3. For PEIA, they'll let you bill for whatever you want to bill for, but they're going to charge a high amount if it's non-preferred on their formulary. And there's their phone number. That's effective until July 1st. And then if you're looking for a non-specialty med, I included our phone number there. If you need something that's not an HIV medication, but that you still need it for their HIV diagnosis, you'd call Rational Drug. And that's it.
Awesome. Thank you guys. We already have one question, which is great. So we had a question that says, the meds for Medicaid have to be prescribed by a hepatologist, gastroenterologist, or infectious disease specialist?
Or in consultation. So for instance, if you've called into ECHO, that would qualify. Or if you say you consulted with one, you can just indicate that on the form and that would be okay.
And do they have to have documentation of that?
No, if you just indicate that you have, that's good enough.
Okay.
That was one of the motivations for this ECHO program to start, was that restriction.
Great.
Hey, I have a quick question for Rachel, and I don't know if you have an answer to it or not, but if so, my understanding is Rational Drug Therapy is a third party that acts between the provider.
Probably a better question.
And and Medicaid. But does Medicaid get data that tells them how many prescriptions are refused? So I'm just wondering if there's any noise, the feedback that goes back to Medicaid for the cases that are F0s and F1s. Do they have any idea how many people were trying to get approved, or are they completely insulated from that information?
If they want that information, we could pull that data and give it to them. What we generally do is at their quarterly DUR meeting, we take down the top 5 classes of medications that are reviewed, and the HIV medications just don't usually come up on that. If they wanted that data, we could certainly give it to them.
What about the Hep C drugs?
The Hep C drugs have not come up on that either. So there's just the stimulants are going to cover that, the antipsychotics, the anticonvulsants. Those are always the top 5.
Well, that's a bummer, because Dr. Rexroth, I was thinking for your case, it would be almost nice to send the request in for the first case, regardless, just to let Medicaid remind them that there's a lot of cases that they're denying. But apparently, if Rational Drug Therapy is
playing interceptor. Well, I would see the ones F2 or less, because they are the ones that deny those.
I still think you should, though.
Oh yeah, I
mean,
still would too.
I still think you should at least try to submit it if you want to appeal or not for the first case, But I think there's no harm in trying,
No.
and then that also kind of builds the case that we are doing what we can as providers to advocate for these patients, and just kind of gives us some.
So it's because those drugs are available to be dispensed for Medicaid at any pharmacy, you could take your prescription to the Rite Aid on the corner or Jerry's Pharmacy, and someone could try to input that claim and submit it. It wouldn't go to, I don't think it comes to you guys when they do that, or maybe it does, meaning that you probably should at least see it, but they should see it.
Cool.
So they're going to see that this claim is denied.
Okay.
That goes to Melina. Have that data.
Okay.
But now, what awareness am I denying here? They might know that number that we've saved X amount of dollars, or maybe they just don't look at it. But I'm pretty sure they know. Cool.
I did talk to BMS at our last DUR meeting in February, and I kind of brought that up, and I talked about ECHO a little bit. And he said it's on their radar, but as of right now, they've got to keep the F2, unfortunately. But it is something they're thinking of, and he said we really want to expand it as soon as possible, but as of right now, they just don't have the money.
I'd like to make one last comment that's not related to Hep C, some changing subjects, but it is definitely true that as a state, we have a relatively small number of individuals living with HIV, but the issue is how many people are attempting to even make that diagnosis. So I think we have a lot more HIV in this state than we know of because so few people are testing. And right, a year and a half ago, there was an outbreak of almost 60 cases across the southern coal fields. last month there was an announcement of a sustained outbreak in Cabell County. I think everywhere this drug problem is substantial is probably at risk. And the reason we're not seeing more cases is because screening is so, it's just not done very well.
Dr. Rexroad made a comment while you were speaking, Dr. Feinberg, that says that they are working on getting the in-house testing for HIV. And sure, Jennifer, go for it.
Right on, Dr. Rexroad. And Jennifer can talk to New River.
Yeah, we have it in-house, and Dr. Feinberg's been helping me really try to light a fire under people here as far as HIV screening, and those numbers from today about Raleigh County, which is within our service district, will help me to keep reminding people. Hey, I have two really quick questions. I think they're really quick. It's nice to be back. I'm told Dr. Feinberg yesterday that I'm dusting off cobwebs on Hep C because we started an MAT program here at New River, and so I'm having a lot of patients referred to me. So I'm preparing some cases for presentation in the next month or so. And my two questions are, if somebody has had documented hepatitis A vaccine in the past, should I still be getting titers to demonstrate immunity to Hep A?
No, I don't think so. I think Hep A is one of those vaccines that has a really high take, unlike hepatitis B.
So just vaccinate and be done with it. And then my other question is, and it relates to one of Dr. Rexroad's cases, because a lot of the people that I'm seeing are just having either transportation difficulties or life difficulties. They have trouble getting off work and their jobs are crucial, blah, blah, blah. If somebody has a low fibrosis score by their blood work, how hard should I work to get, and how hard should I work to get an ultrasound for them?
It's a hard question. It's a great one you're wrestling with, because I would say it takes the complete clinical assessment, time period of like the time they've been infected, the age of the patient, other comorbidities, your pretest, that annoying thing we always tell people, that your pretest probability, which
right.
So
okay, well, that's actually a good, that answer gives me, because I have all these cases coming up and I can factor all that in. And
with 2 years of diagnosis, probably not terribly crucial for the 55-year-olds with other stuff. Yeah, but it's a great question. We wrestle with it all.
That's beautiful. Thank you.